Hello everyone. So today I'm going to be talking about my nursing topic of day 5, which is what is nephrostomy and the care for nephrostomy. So a nephrostomy is a tube which is a narrow gauge pigtail drain inserted into the renal pelvis for the purpose of draining urine. The percutaneous nephrotomy tube diverts urine away from the ureter and bladder into an externalized drainage bag. It is usually inserted by an interventional radiologist under direct vision using fluoroscopy, ultrasound, or computerized tomography, which is CT, guidance, while using local anesthetic and often sedation. Nephrostomies are used in a range of situations. For example, urinary obstruction, which is the most common reason for a nephrostomy. And urinary obstruction is usually indicated by the acute renal failure, loin pain, nausea and vomiting, fever, as well as urosepsis. Nephrostomy tubes are also inserted for urinary diversion, for example, in situations like a urethral injury, urethral fissure, hemorrhagic cystitis, stenosis of urostomy, and herniation of urostomy. They can also be used to provide access for therapeutic interventions such as stone removal, anti-grade stent insertion, removal of foreign bodies such as broken urethric stent, delivery of medication, urethral biopsy. Nephrostomies are also used in some diagnostic testing, for example, antegrade pylography and urethral perfusion test. Now, the principles of care are usually looking at the risks of nephrostomy, for instance, severe bleeding, vascular injury, damage to the adjacent structures, or the tube occlusion or replacement. We also have to take a look at the infection risk and wound care, where patients with nephrostomy are always at risk for pyelonephritis, which is inflammation of the kidney, and it is usually due to infection from the foreign body puncturing the kidney. They should be often monitored for signs and infections or sepsis, for instance, loin pain, elevated temperature, fever, or chills. Drainage bags should be changed every 5 to 7 days, while good hand hygiene is vital when handling the drain and exit site and emptying the drainage bag. Nephrostomy tubes should be routinely changed every 3 months as recommended by the manufacturer of the bag. The nephrostomy bag should be emptied when it becomes 3/4 full and when appropriate. The patient or carrier should be taught on how to do this. At night, the patient or the carrier should be taught to attach a larger volume night drainage bag to ensure a comfortable night's sleep. When a patient returns, or daily management of equipment and patient comfort is that we have to ensure the nephrostomy is secure at all times when drainage fixation dressing. We also have to check drainage tubing is patterned and not kinked or twisted. If urine output is less than 30 milliliters per hour, we have to inform our medical team and also look into what is going to happen. We should apply drainage bag at insertion and empty drainage bag using clean techniques when no more than 3/4 full, and record volume on a fluid balance chart. We also have to ensure pain is well controlled and, if necessary, administer prescribed analgesia, for example, paracetamol, tramadol, and codeine. Unless otherwise directed by interventional medical team, we have to advise patient to drink fluids and eat light diet and post-procedure. We also have to mobilize patient from the bed to chair and check insertion site daily for bleeding, infection signs like pain, redness, swelling, and leakage. That is all from me today. Thank you so much for listening.